All right, guys, welcome to part 2 of non-invasive positive pressure ventilation. In part 1, we talked about CPAP, which is continuous positive airway pressure. We talked about how that is used for COPD patients, people with obstructive sleep apnea, people who have exacerbations of the COPD, CHF, pulmonary edema, refractory hypoxemia, which is shunting. All those things are for CPAP. Now we're going to talk about BiPAP. To be honest with you, BiPAP is actually a registered name by the company Respiratory. Respiratory came out with BiPAP in the 1990s. They were really the first one, so we just call it BiPAP. And there really is only one manufacturer who truly supplies BiPAPs to hospitals. So if you say BiPAP, everybody's going to know what you're talking about. If you say bilevel positive airway pressure, they may not know what you're talking about. However, that's what your book calls it to save namesake of the registered name from Respiratory. Okay, anyway, so BiPAP, it has two levels. It has an inspiratory level and an expiratory level. That means that with BiPAP, you set two levels. Inspiratory positive airway pressure is up here. This is the pressure you're going to set for the patient to inhale. If you set an inspiratory positive airway pressure at 10 centimeters water pressure, they're going to breathe in 10 centimeters water pressure with every breath. And then we set an expiratory positive airway pressure. This is the pressure that the patient has to breathe out against at all times. The inspiratory positive airway pressure will always be more than the expiratory positive airway pressure. The inspiratory pressure we call IPAP, IPAP, inspiratory positive airway pressure. The expiratory positive airway pressure we call EPAP. So with BiPAP, you have your IPAP and your EPAP. And just to blow your mind, EPAP down here is the exact same thing as CPAP, which again is the exact same thing as PEEP. So if somebody says PEEP or CPAP or EPAP, they're all doing the same thing. They're increasing the FRC, they're getting rid of the shunting, they're helping the oxygen. So either EPAP and the CPAP and the PEEP, those are all fixing oxygen problems. Inspiratory positive airway pressure is helping the tidal volume. So this one up here helps your CO2. If I increase my inspiratory positive airway pressure, that means that I'm going to increase the tidal volume. If I decrease the inspiratory positive airway pressure, I'm decreasing the tidal volume. This would be maybe a tidal volume of 200. I see that my CO2 is not getting blown off, so I need to increase my tidal volume, my minute ventilation. So I increase my inspiratory positive airway pressure. Now my tidal volume is this big. I'm blowing off more CO2. So here it is in a nutshell. IPAP, inspiratory positive airway pressure, controls your CO2. The higher it is, the more CO2 you're going to get rid of. Your EPAP down here, that's for your oxygen. CO2, oxygen. IPAP, CO2, EPAP, oxygen. Okay? So just to review, CPAP only fixes oxygen. CPAP will not fix CO2 issues. If you get an ABG on a patient and their CO2 is high, they need BiPAP. Again, CPAP's for oxygen, BiPAP is for CO2. All right, so you know CPAP has one continuous positive airway pressure level. Yet BiPAP has two levels, the IPAP and the EPAP. The IPAP again is for CO2, the EPAP is for O2. The difference in between this level and this level, this area in between here, we call that pressure support. So basically what you're giving a patient is CPAP. That EPAP, remember, is the exact same thing as CPAP. Let's say that our settings are 10/5. I have IPAP of 10, inspiratory positive airway pressure of 10, EPAP of 5. That means that my peak inspiratory pressure is going to be basically set at 10. That's basically what that means. My EPAP again is the same as CPAP, so that's set at 5. The difference between the two, the area in between here, that's called pressure support. So this is the continuous positive airway pressure, and then the patient's going to get that umph, and that's the inspiratory positive airway pressure. So they've got their lungs full of 5 centimeters of water pressure at all times. When it's time for a breath, the machine says, oh, time to give 10 centimeters of water pressure. They get that umph on top of that 5 that's already in there. So if you have 10/5, that means your pressure support is 5. Because the difference between the IPAP up here and the EPAP down here is pressure support. So 10/5, 10 minus 5 equals 5 of pressure support. Why do we care what the difference is? Because the more pressure support somebody has, the more CO2 you're blowing off. Again, the difference between the IPAP and the EPAP is how big that tidal volume is. So in essence, we're saying the bigger the pressure support, the bigger the tidal volume. The bigger the tidal volume, the more CO2 we're blowing off. If we decrease that IPAP, we're decreasing the pressure support, we're decreasing the CO2 that's going to be blown off. This slide says that pressure support is the treatment for hypercapnia, hypoventilation. What that means is hypoventilation. They're not breathing enough. They're not getting rid of their CO2. If somebody's not getting rid of their CO2, they are hypercapnic. There's too much CO2 in the blood still going round and round throughout their body. So if they're hypercapnic, they're not blowing off CO2, they need pressure support. They need that that bigger tidal volume to open up their lungs so that they can get rid of their CO2. Again, it helps prevent intubation. If we've got a patient who has an ABG of maybe 727, their CO2 is 56, and their bicarb's 24, they're having issues with CO2 to the effect that it's changing their pH. We can actually put them on a BiPAP, give them that pressure support, that difference between IPAP and EPAP, give them some pressure support, give them that extra tidal volume, blow off their CO2, and they may never even need to be intubated. So it prevents intubation in that way. And again, we can use BiPAP for sleep apnea. Most commonly we do use CPAP, that continuous positive airway pressure. That CPAP splints open these airways and allows air to get in, stops the snoring, all that stuff. But sometimes the patient's sleep apnea is so bad that their CO2 builds up. So we can use CPAP or BiPAP, either one, for obstructive sleep apnea.